In this video, we'll discuss about radicular cyst. So, it is the most common odontogenic cyst, most common inflammatory odontogenic cyst, which occurs in relation to the apex of a non-vital tooth. Now, there are three things to remember in this definition. First of all, it is inflammatory in nature. Second, it occurs in association with apex, and that too of a non-vital tooth. Now, in other names, we have the root end cyst and the apical periodontal cyst. Now, coming on to the pathogenesis. Pathogenesis of radicular cyst is quite interesting and easy to understand. Just let me adjust the lighting. Yeah. So, in pathogenesis, we have basically four stages. The first one being the initiation, then the proliferation, then the cystification, and then the enlargement. Now we will discuss how the events happen. So first of all, if there is any caries or there is trauma or there is a periodontal pathology. Now in presence of all these, there will be the death of dental pulp. These all will lead to the death of dental pulp. Now due to the death of the dental pulp, what we will see is there will be release of bacterial endotoxins from the necrotic pulp. Now these will initiate a humoral response with formation of antibodies. Now this will lead to increase in the vascular permeability. So basically this is the initiation of apical bone inflammation. Now due to increased vascular permeability, there will be infiltration of T lymphocytes, then release of IL-1, IL-6 and pro-inflammatory agents. Then we will see that the activated cytokines now these activated cytokines, they will stimulate the rest cells of molluses, which will lead to epithelial proliferation, then cyst formation, and then enlargement. Now, just to give you a rough idea, suppose this is our pulp, okay, and then what we see is there is necrosis and death. Now, what you will see is a lot of cells, rest cells of molluscs get stimulated. Now, you need to have a lumen, right? So, what will happen is the central cells. This is very important point, which is oftenly confused. Now, these central cells, right? They won't get the nutrients, all right, that are needed for them to grow, due to which they will undergo liquefactive, basically ischemic, liquefactive degeneration, necrosis. Now they will die away and this will be the lumen of the cyst. All right, now let's discuss about the epidemiology of radicular cyst, the apical periodontal cyst. Now, yeah, first we'll discuss about the types. Now, either it can occur like this, all right, or it can occur basically like this, or it can occur, suppose this is our teeth, right, and it can occur like this, all right, or it can be basically suppose you have this and it is here, no teeth is here. Now this one is the true radicular cyst, all right. It's basically the epithelial lining lining does not touch the pulp or is not connected to the pulp. Now this one is the lateral. Okay, this is basically arising from the accessory root pulp basically. Okay, now this is the important thing. This is basist, or you can call it as pseudocyst. Okay, in this the cystic lining is actually touching the pulp chamber or the pulp. This is basically a false cyst. All right, why is it called as bay? Because if you know Bay of Bengal, right? So just like a river is like this, right? So it is in this position. Now what is this? This is a residual cyst. Now if there is an incomplete enucleation or there is a recurrence, okay, so this is basically radical residual cyst. Okay, incomplete removal of radicular cyst leads to the formation of the residual cyst. Now, coming on to the age, it usually occurs in the more than 50 years or second, third, fourth decade. You can write, and then it is showing male predilection in sites. Basically, it occurs in the anterior region. That too uh, in the canines and the premolars. All right, now let's talk about the clinical presentation. Now in the clinical presentation of radicular cyst, what we see is that it is basically a localized painless swelling, right? So we will write about it as localized painless swelling. It is usually asymptomatic, painful when secondarily infected. Then you will mention about expansion and distortion of cortical plates. Then a very important thing is the springiness of jaw bone when digital pressure is applied. Then discoloration of teeth, malocclusion. All right. Now let's talk about the radiographic features. First of all, you will see a well-defined unilocular radiolucency around the apex of the root. Okay. Then you can also see a semicircular radiolucency. Loss of lamina dura is a very important point to mention. Loss of lamina dura. Then then you can just mention about how the thinning occurs and all. Now we will talk about the cystic fluid. Now in this cystic fluid, it is also straw colored. Uh, it has cholesterol crystals. Yeah, let's talk about the histopath. So now coming on to the histopath, what you will see is it actually contains 6 to 20 cell layer of non-keratinized stratified epithelium, columnar epithelium. So yeah, and then uh, there is edema, there is inflammatory cell infiltration. Now 3 points you must always mention when you're talking about radicular cyst. First is the rushed on bodies. Now what are rushed on bodies? They're basically eosinophilic hyaline bodies that are present in the epithelium. Hyaline bodies. Now the second point you must mention is the Russell bodies. Now what are Russell bodies? These are basically our plasma cells that have immunoglobulins surrounding them. Okay, and the next point that you must mention is the cholesterol clefts. Now why are cholesterol clefts formed? This is a very common question which is asked in viva. Basically what happens is when you do the staining, right, and when you make the slide, the cholesterol, it washes away the stain on it. So due to that reason it appears to be as empty spindle spaces. Now very important point mentioning about the pattern is the arcading pattern. Now this is very important. If you mention this, you're going to get marks. Now what happens is basically the cystic epithelium, it grows in a peculiar fashion. That is, it encircles the mass of connective tissue. What you see is it appears to be like this. This is basically the arcading pattern of the epithelium. Then we can also mention about the uh, edema. Yeah, we've mentioned about edema. Then there are areas of inflammation. Also, yeah, there will be presence of mucus secreting cells. Also, there are focal areas of keratinization. Now, in differential diagnosis of the periapical cyst, we have periapical granuloma, we have periapical abscess, central giant cell granuloma, cementoma. Now, in treatment, in true cyst, what we do is we extract the involved tooth extraction plus the complete curettage. Whereas in case of bassist, in this is basically pseudocyst. So what we do is we first of all do the episectomy of root canal tip, and then we do RCT. So this completes the radicular cyst. Now, for the histopath diagram, you can draw any of these two. The first one being this. So you see connective tissue, arcading epithelium, ovarian thickness, and lumen of cyst, and chronic inflammatory cells. All right. In this is very characteristic arcading pattern, right? These are the rushed-on bodies, highly eosinophilic bodies, chronic inflammatory cell infiltrated, demonstrating the inflammatory nature. This is the lumen, then connective tissue capsule. So this completes the radicular cyst. I hope you understood. Thanks for watching.